Welcome back to The Wellness Effect. Hit that subscribe button so you don't miss out on any of our previous or future episodes. In our previous episode, we looked at the current state of the HIV and AIDS epidemic in our country. In this episode, though, we discuss the difference between the two, as well as what treatment options currently exist. My guest in this discussion is Dr. Jireh Serfontein, a specialist in the field of sexual health care and part of the team at My Sexual Health. Welcome, Dr. Serfontein.
Thank you so much.
So, Dr. Serfontein, could you explain to us the difference between HIV and AIDS?
Yes, so I think the principle is in the name. HIV is the abbreviation for human immunodeficiency virus.
Sure.
So that's just the name for the virus. So you can have a virus infecting you without causing a disease process. AIDS is acquired immunodeficiency syndrome. So that's the disease process. So not everyone living with HIV will get AIDS. So basically AIDS is the end product or the end result of untreated HIV. So in today's day, we are not supposed to see HIV progressing to AIDS anymore. So the difference is HIV is the virus, the name of the virus, and AIDS is the end result, the disease process caused by the virus if not treated.
What are the treatment options for HIV and AIDS?
So the first thing to understand is the treatment is targeted to prevent the HIV virus from replicating.
Okay.
So it's antiviral medications that there's different ones available, and it all depends on where in the replication cycle it blocks the replication. So by blocking the virus, we're going to prevent the virus from becoming more, and then it's not going to infect the body further.
Sure.
And in that way, we decrease the viral load. And we'll talk about that a bit later. But if we can decrease the viral load, then we are going to slow down the disease process. And if we can get to a point where the virus is totally blocked, we're never going to progress to AIDS. So by treating HIV, we are blocking the virus, preventing AIDS. Another analogy that I often make is that imagine there's a car on a highway.
Yes.
Okay, so in the middle of the highway, there's this big wall and the car is going to crash.
Yes.
So when the car crashes with this wall, that's when we hit AIDS. Now, the disease, so the end result is hitting the wall, but the speed of the car is how much virus is in your body. We talk about viral load. So the higher the viral load, the quicker we are going to progress to AIDS.
Okay.
The distance between the car and the wall is something we talk about as the CD4 count. So once HIV enters our body, it looks for CD4 cells, which is part of our immune system. And then it uses the CD4 cells to basically as a factory so that they can start producing more and more HIV particles. And in that way, the virus starts to bring down the CD4 count. And like I said, the distance between the car and the wall is the CD4 count. The lower the CD4 count, the closer we to the wall. So the idea with antiretroviral medication, and that's the treatment for HIV, is we slow down the car.
Okay.
We bring down the viral load, and in that way, the body can recover. The CD4 cells pick up, and we're actually going in reverse. We're moving away from AIDS.
And do you find that maybe, is there still a stigma when it comes to having HIV and AIDS? And are more people, because of the stigma, not wanting to get, treatment just at, the HIV/AIDS stage of the virus?
So luckily, we are seeing less AIDS compared to, for instance, 20 years ago. But unfortunately, HIV is still such a stigmatized condition. And because of that, people don't disclose their status and they don't get treatment. I often say having HIV is not the end of the world, but having HIV and not knowing it, that's the problem. Because if you're living with a condition unknowingly, you're never going to seek help. And if you don't get help, you're not going to start with treatment. If you're not going to start with treatment, we're not going to block the virus. And the more virus you have, the higher the probability of transmitting the virus to someone else.
Correct.
So if we can break the stigma, more people will get tested, more people will disclose their status, more people will be on the medication to a point where the virus is fully suppressed. And that's also part of prevention of HIV.
Doctor, could you tell us about these alternative treatments such as injectables?
So yes, I know injectable ARVs has been a lot in the news and a lot of people are talking about it. So the principle behind that is that there is a certain drug called cabotegravir, which is an antiretroviral medication that can be formulated in an injectable. And it has been approved to prevent HIV replication, and in that way we can treat HIV, but it's only been registered in South Africa as HIV prevention, as pre-exposure prophylaxis. So ARVs can be used in for different reasons. Firstly, to treat HIV, but also as HIV prevention. And we can talk about the prevention strategies a bit later. But the injectable has been registered in South Africa only as a prevention strategy, not as a treatment option. And the other difficulty is that the injection is not readily available yet. So it's been registered, but it's not available.
Okay.
So people are waiting for that. But when it gets available, it's only going to be used as a prevention first. And there's a lot of work still to be done to get to a point where we can use injectables as treatment.
Maybe let's talk through some of the prevention strategies that you just touched on.
When we talk about the prevention, you get pre-exposure prophylaxis, or PEP, or post-exposure prophylaxis. Pre-exposure prophylaxis is PrEP, P-R-E-P, sorry, and post-exposure prophylaxis is PEP. Now, PEP, or post-exposure, it's in the name again, after exposure. So for instance, if as a medical doctor or someone working with patients, I contaminated myself or accidentally pricked myself with a needle, there's been an incident, and post that incident, I'm going to take prophylaxis and I take HIV preventative medication, which is the same ARVs that we use to treat HIV, and I only take it for a month. In that way, we prevent the HIV from replicating to a point where it can start infection. And then we use that post-exposure prophylaxis. Pre-exposure prophylaxis, we take the HIV medication prior to exposure. So we are aiming to use that for high-risk population groups. For instance, sex workers, men who have sex with men, transgender population, younger girls that can't really negotiate condom use. We want those high-risk populations to be on pre-exposure prophylaxis. And then they take ARVs every single day to prevent HIV. But it's very important to get HIV testing quite regularly and quite frequently so that they can pick up if they get infected. Because the difference is the pre-exposure prophylaxis is only a combination of 2 ARVs, where the treatment of HIV is 3 ARVs. So we're worried that if we use only 2 ARV drugs, we can gonna feed HIV resistance. So I don't want to complicate it too much, but that's basically the difference: pre-exposure prophylaxis and post-exposure prophylaxis.
So, Doc, you deal with HIV and AIDS on a day-to-day basis. What are some concerning things that you're seeing? And maybe, I know you might not be able to answer it, but why aren't we completely eradicating it from society?
So I think the big thing there is people don't get tested. So like I mentioned earlier, that having HIV is not the problem. So in 2014, the UN AIDS set up targets internationally and globally to say that by the year of 2020, we want 90% targets. So they wanted that, they said that hoping by 2020, 90% of people having HIV should know their status. Of those knowing their status, 90% should be on treatment.
Correct.
And of those on treatment, we are hoping that 90% should have an undetectable viral load. But we were slow to meet those targets. And then they changed the targets a bit later and said we wanted, instead of 90, to be 95%. And in 2022, they did a survey, and we weren't far off that. So in South Africa, the stats for people knowing their status was around 90%. So it's not 95%. So the problem there is that in South Africa, there's still 10% of people living with HIV and not knowing it.
Wow.
And if you don't know your status, you've got a lot of virus active and you can transmit the virus unknowingly. But if we can just get testing more frequently and get open around getting not just HIV itself, but STIs in general, break the stigma around it, get tested, get those that's living with HIV on treatment, then we are going to meet those targets. So the big concern that I see is that people don't talk about their status. Unfortunately, I still have couples in my practice where they haven't disclosed their status to long-term partners. But if the viral load is undetectable, you can't transmit the virus to someone else. So I think the key thing here is we need to educate and get tested and be on treatment.
So, Doc, as we end off the discussion, are there any key takeaways for our viewers that you'd like to share?
Yeah, so I think the first thing is know your status. So regular testing is very important, and don't think to only get tested when you enter a new relationship. In South Africa, most of the HIV infections that we see are in long-term committed relationships. So you don't get tested because you don't think about it. So everyone should get HIV testing yearly. Ask to see someone's test if you start a new relationship. Use condoms and just have open communication and discussions around sexual health.
Thank you for such an insightful conversation, and we're wishing you all the best.
Thank you so much.
Remember to like this video and subscribe to our channel so you can catch every episode of The Wellness Effect. Till next time. BankMed, the medical scheme of choice for the financial services industry. The Wellness Effect is proudly brought to you by BankMed, yours in good health. Welcome back to The Wellness Effect. Our first episode in our series on HIV and AIDS took a look at the current state of the epidemic in South Africa. In this episode, we explore the discussion even further, focusing on the modern treatment and management thereof. We're joined by Dr. Jireh Serfontein, part of the team at My Sexual Health, a multidisciplinary team of sexual health professionals. Welcome, Dr. Serfontein.
Thank you for having me.
Thank you for joining us today. Thank you, Dr. Serfontein, for such an engaging and insightful conversation.
It's a pleasure. Thank you for having me.
Unfortunately, we'll have to leave you there, but we'll continue this discussion on our YouTube channel. Join us there for the full conversation, and remember to subscribe so you don't miss out.